My name's Noelle Skivington. I've got various hats on, so I'm a board member at Healthwatch, is my usual role, but I'm acting as chief exec for the moment until we recruit another chief exec. So most of you will know about Healthwatch by now. I'm not going to say too much about that sort of the work we do, but we like to think we provide a one-stop shop for information about health and social care services in Enfield. That's the whole range, so GPs, hospitals, dentists, pharmacists, etc. And also social care and care homes. We look after the Barnet Enfield and Harringay Mental Health Trust as well, and as I say, we try to do our best with social services and care homes, which is challenging at this moment in time. We've set up this particular session because we're really conscious of the changes, particularly with COVID, what's been happening, and people are just not clear on what is available to them, how they should access them, and how we can move forward. And also some uncertainty about what's the right thing to do. So hopefully we've got a whole host of questions, as I said. Hopefully at the end of the day there'll be some clarity. But if you want to ask questions, then you can use the chat box and we will try and put those in as well. There is an evaluation survey that we'd like you to do at the very end. So again, if you could spend some time before you leave us and fill that in, we'll be really grateful. We have quite a good panel, and I'm going to just hand over to the panel and let them introduce themselves. So can I start with Natalie Forrest?
Natalie, you might be on mute. We can't hear you or see you at the moment.
Oh,
you
can't
we've
hear.
Got you. Yeah, no, we've got you now. Hello.
Good morning, everyone. Thank you very much, Noelle, for inviting me to join in this morning. It's a very tricky time and quite anxious for everyone, so it's a lovely opportunity to be able to answer questions and give people some clarity. So my name's Natalie Forrest and I'm the Chief Executive at Chase Farm Hospital, and I look forward to answering questions this morning. Thank you.
Thank you very much. Amy, would you like to go next?
Yeah, can you hear me? My name is Amy Wood. I'm the Head of Quality Governance and Patient Experience at Chase Farm Hospital.
Thank you again for joining us. Emma Witcher.
Hi, I'm Emma Witcher. I'm the Medical Director at North Mid, and I'm really delighted to be speaking to everyone today. I just wanted to make a quick comment that you know, we continue to have the full range of services at North Mid, and you know, if people are worried about their health, please seek advice through your GP, through 111, but services are open and are treating people.
Thank you, and thank you for reminding us of that. That's obviously really important. Dr. Garg, I hope I'm pronouncing that correctly.
You're absolutely right. My name's Anukul Garg. I'm a service lead for diabetes and endocrine at North Middlesex Hospital, and also a consultant in medicine. And I would like to echo Emma's words as well. We're fully open to service. We had a bit of backlog. We've got up. And if you are still worried not to come to hospital, we've got other ways to kind of help you, support you, check your sugars, etc., etc. So I'm more than happy to talk later about that, but we are open for business completely, 100%.
Good, thank you. That sounds exciting. Dr. Sarit Ghosh.
Hi, I'm Dr. Sarit Ghosh. I'm a GP in Medicus Health Partners. I'm also a clinical director for Enfield Unity Primary Care Network and co-chair of Enfield Gp Federation. I'd like to probably echo my clinical colleagues that although there may be some barriers which we'll probably talk about later on, primary care is also open for business and are working very much collegiately with hospital colleagues to ensure patients get the best care that they can in the current context. So I'm sure we'll talk a bit more with the questions that you've all asked.
Thank you. And Renata?
Hi everyone, I'm Renata Chavd. I'm Head of Operations at Enfield Gp Federation. Just to give you a quick overview, firstly, thank you for inviting us today to answer some questions and provide some clarity. Our federation consists of 47 GP practices in Enfield, and basically we're delivering programs via the practices such as wound care, diabetes, etc., local services. We work closely with GP practices and also our primary care networks. We're a very clinically driven organisation, and we try and work collaboratively with various organisations across the system, whether it's community services, voluntary or secondary care, etc.
Thank you again. And Fahim Chowdhury?
Oops.
Stay on the call.
Let's have a look. No.
I think not at the moment. Apologies for that. And I believe Dudu is not on the call either at the moment, is
Yeah,
she?
we haven't got Dudu yet.
Okay, so hopefully they will join us in due course. Have I missed anyone out? And apologies if I have.
No, you've gone through everybody. It was just the last two that are on the call at the moment. But given the industry that we're in, that's hardly surprising people get these last minute emergencies.
Absolutely. Well, we've had an IT glitch to start with, so we're lucky everyone's here, and as I say, very grateful. I don't know if any of the speakers want to add anything before we go into the questions, but I'm happy to go straight into the questions. I'm going to take that as a no then, and we're going to move on. So the first question is looking at GP access. And it's about privacy, and it's a topic that actually comes up repeatedly with Healthwatch issues or the callers that we get. And it's about why do receptionists need to ask about medical things, about why they want to see the doctor. And this has been brought up as some people are not prepared to discuss their medical problems with the receptionist, and it therefore becomes a barrier. And the question is there any way around this? So I don't know who wants to take that one.
I'm happy to take that one. I think it's really important to understand that in primary care, what we want to do is, and secondary care as well, we want the patient to see the right clinician at the right time. And to do that, we need some information. Now, we're going to talk about digital later on in some of the questions. And a lot of that, if you reflect your medical problems or queries on that digital platform, whether it be e-consult or a different way, that's an alternative way of bypassing the receptionist. And a lot of practices are encouraging this way because it improves the responsivity of primary care. Previously, if you rang a doctor, you may be seen in 2 weeks, 3 weeks for a routine problem, sometimes 6 weeks in some practices. Embracing digital has enabled you to bypass that to an extent, and often we are responding to patients within 24 hours because we're able to see that the simple non-complex problems can be dealt with quickly and the more complex problems can go to the right person. So that's the principle of why receptionists ask for more information. For those who are digitally excluded, I do encourage that you share as much as you can. You may not be comfortable to share as much as you can, because that would enable you to be your problem to be dealt with promptly. Everyone's bound by a confidentiality agreement as an employee of the practice or a partner there. So to reassure you that information shouldn't be shared widely, and there are controls in the EMIS system, our patient record system, to support that principle. So hopefully that will sort of answer that element.
To some extent, does anybody want to?
Noel, it's Alpesh. Can I just come in on that and just reiterate it? So, sorry, I've not got my camera on. I've got my mask on. I'm with other people. The other thing that I would say is that often it helps us to prioritize conditions significantly. So if people have got chest pain, if they've got other manifestations that warrant a much more immediate response from their practice, it really is helpful in helping us gauge the severity and the speed with which we need to advise people to access care. So I think it's very important, but I would reiterate everything else Sarit has said.
Thank you. You will have realised I've got dogs in the room and someone's just come to the door. I apologise for the barking. Can I just pick up on one point, though, that it is probably not as relevant, or it doesn't happen as much with COVID, or it may be worse, but we've heard examples of where people are being asked to stand in the doorway and shout what their problem is to the receptionist, which I know is for separation of the COVID, but actually when you're sitting also in GP waiting rooms, sometimes you can hear what's being discussed and you can identify who that person is. So Is there a way around that, do you think?
Yes, yes. So, go on, Sarah.
No, I was just going to say that I think it's not ideal. There are ways around it. I think initially in the pandemic, there was a lot of anxiety everywhere, really, and doors were early on in the pandemic. Some doors were closed, and then there was a reluctance to allow patients into the practice. But as I said, there are different ways of requesting help. There are online ways of requesting help. But if you come to the practice, be open, and you can sort of socially distance within waiting rooms to an extent. But there are also screens there as well to protect both patients and staff. So I guess, I don't know what else you've got to add, Alpesh, but I think that individual practice layouts really determine how best the flows of patients work for patient and staff safety. And I guess it's difficult to have a uniform answer to that question.
Yeah, and all I would add to that is that often if you ask the reception team about a more private space to have a conversation, I'm sure those are available. So there are a couple of things, isn't it? One is information and how it's relayed and the privacy with which it's relayed. Telephones give you that privacy, and so I suppose what you're asking is what happens on a face-to-face basis, that I'm sure practices will have processes that do allow a more private conversation.
Receptionists are just being nosy. But I think that, yes, things have changed a bit. I think they need to have.
So Noel, you're muted, I think.
Yes, I was saying that I had that question in the chat as well from someone who had experienced it recently. I'm just going to move on because you mentioned digital exclusion, and I just want to pick up on that. And what we're being told is that people are finding it, they don't have internet access, they don't have a smart device, and they need to get it, and they're being told they need to get a friend to complete the online forms. They don't want their friend to know about the medical conditions, which is fair enough, and they want to know why they can't book an appointment by the telephone and be seen by the GP face to face.
I'll take this one as well because I think it's particularly relevant because our group of practices really did embrace the digital platform. I'll give a bit of context. The NHS digital strategy in the 5-year forward view really does promote digital access for patients. And during the pandemic, there was a strong push with remote consultation to transition to digital, and to do that in a total triage sort of fashion. And that sort of means that the majority of patient access to be provided through digital during the pandemic was preferred because one, it allows us to prioritize and streamline effectively. And two, it allows greater responsivity for the system. So as I said, we were able to and are able to respond to patients' queries within the day usually, but there is a trade-off for that. And because we implemented and deployed it really quickly, there wasn't enough time to engage with patients.
A bit short though, isn't it?
Sorry, I think someone's speaking. Could I ask those who are not on the panel to turn their microphones off, please?
Yeah, so it was really, we had to deploy really quickly and couldn't engage patients effectively because of the pandemic. So what that's meant is that there's been some mixed messages for patients. It almost seems that digital or nothing, and that's not the intention, because we fully recognize as a system, as a provider, that patients need different ways of accessing services, and telephone it is a very important method. However, what the total triage sort of model, and not every practice has embraced this, means that is that if we are to continue to respond to patients really quickly, we can't do both total triage and telephone. But by moving to digital, we've moved reception staff to managing all of those digital e-consults. So we can't man the phones and have equal telephone access to digital. Access is finite, and we have to, have a threshold for both. And that's why we're working with the NHS digital team to sort of map the best pathway for the patient. So, for example, for our super partnership, Medicus, we've realised that patients need more phone access, and that we can't process entirely digital. So we were getting about 3,000 digital requests a week that we were processing. So if you do that on top of your telephone request, it wouldn't be manageable. So we've realized that we need to cut back on some of that digital. So we've cut down the hours a little bit of when you could submit. So that gives us some more time to deal with proactive care and for patients who are complex, who are digitally excluded. So we're all learning on this process with patients. But I think the most important thing is that although it was deployed quickly, what we are seeing is that we're able to respond to patients really quickly. What patients are finding is that they're getting mixed messages about digital or nothing, and that isn't correct. There is eConsult Lite, which is a telephone way of triaging. There is that there. And what we're trying to do is get the consistent message from our front office, which is receptionists, to patients to share that message. And I think that's where it's sort of fading a little bit, and we're working hard to make sure that's changing.
Well, I mean that is a really big question, and it's even more complicated than that, because we're getting a lot of feedback, and I'm glad you mentioned eConsult Lite. We're getting a lot of feedback that the eConsult system itself, even when you're IT literate, is very, very difficult to work your way through, particularly when you're anxious and ill. And so there is something about not just educating your staff, but educating the patients about how they can get through that. Where do you see the responsibility for that lying? How can we make that happen?
So so North Central London, I think as part of a national strategy, reviewed the online consultation digital providers, and I think eConsult is something that they've approved and is the preferred choice in North Central London. I would say I don't think any digital software is fully fit for purpose. You can't pigeonhole patient conditions into neat little packages, and I think it's iterative. They're continually learning about changing the pathways, and we do feedback to them, and that a lot of, we've got the same feedback. Like patients tell us all the time that, look, it's not, I had to go down this pathway because it wouldn't reflect my problem. It's not ideal. We understand that. We're sort of, our hands are a little bit tied, and it lies with NHS Digital to find out what the best solution is for patients. And I think that will happen over a number of years, really. I don't think the technology is quite there yet. In the meanwhile, what we do is encourage patients to do it as best they can with the you know, as I said before, the advantage is we are able to respond to you quicker. And that is that it might take you longer to fill out these forms, but that means less of a wait. The previous 2 to 3 week waits shouldn't be happening. And I can say from my providing, it isn't happening. We're dealing with things within a day or two at most.
The other thing I would say, Noel, is that the reason that some of the questions can be quite prolonged is because of the way people are entering the system with the symptoms that they have. So the more complicated symptoms need many more questions to allow a safe response from the system. What you don't want is lots of people being pushed into an urgent pathway when they don't need that pathway, and that's what happens when the more complicated problems are presented and described on the eConsult. So it's designed for safety and to allow the most appropriate signposting to the next service, and that's why it takes so long.
Okay, yeah, thank you. So I've got an example in the chat again. I've got somebody who has a 91-year-old mother who's deaf. I know that feeling well. My 91-year-old mother was extremely deaf, and sometimes they can't be heard properly. They can't respond properly. So how do we overcome that? And I have in my head that is there something around the telephone conversation with the receptionist who would use the eConsult Lite and fill in the data for them, and then that would be fed back to the GP, and the decision would be made to either contact that patient or whatever the outcome would be, to refer to a pharmacist, or whatever the outcome might be. Is that the way for people who are having difficulty?
Yeah, so I think what we've observed, and I'm being completely candid and transparent, was that because we pushed the digital so much initially, receptionists were strongly advising patients initially in the first few months to use this platform, because as I said, otherwise we couldn't do both. But we've been working with our reception front office to really, where patients cannot, in this 91-year-old with hearing impairment is a classic example. You can't expect a 91-year-old to be au fait with the digital. So eConsult Lite, the reception should support the patient to go through that, and that will be put on a doctor list, the same as the eConsult, or another clinician list as appropriate. You're muted again, Noel.
You mentioned again that this was North Central London digital first team looking at this and being responsible for this. So is this applying to all practices across these lessons being learned? Is it applying to all practices across Enfield?
Yeah, to an extent. As I said, I think different practices have embraced it differently for various reasons. And I think there'll be a stronger push from commissioners that everyone embraces it over time. So everyone is working at their own pace, which is good in a way because it's allowing patients to journey with them. I think it's important that the learning from the people who have embraced it is shared, and we are doing that with the digital team.
Thank you. I'm going to move on to a slightly different question, which is about the vaccine. I think the times might have moved on since this question was asked. I'll ask it as the question, but you might want to put it in a different context. So if GP practices have to administer the COVID vaccine, how are they going to do this among their other services? And as you can't see or speak to a GP now, or as it's difficult to, how will this affect the service that the patients receive? And I don't know how up to date, there's been announcements this morning, so that might have changed even as we are speaking.
Abish, do you want to take this one, or do you want me to?
Yeah, I can. So the difficulty here is that there's been a lot of stuff in the news about different types of vaccine and how the vaccine is sort of transported and how stable it stays. And there are two things about which cohort of patients are going to be prioritized and which vaccine is going to be available first. The one that's been in the news this morning as being signed off by the MHRA is the Pfizer vaccine. And the issue with this vaccine is that it can't be moved too many times before it's felt not to be stable and effective. So that will have an impact on which group of patients are allowed to be vaccinated with it. And there's an organisation called the Joint Committee on Vaccination and Immunisation that's going to report later on today or tomorrow about which groups are going to be prioritised. So really, until we have a lot of that information, it's difficult to say. There's about a 10-day lag between the sign-off from both sets of organisations and the first deployment of the vaccine. So it's still very early to give any definitive answers at the moment.
I would say is that the practice sites that are approved in Enfield, there shouldn't be any disruption to their day-to-day GP services. It will be designed around maintaining levels of care. I think it's really important. We've learned a lot during the pandemic that patients haven't been accessing care, especially early on. We have to play catch up. So we're not going to delay that anymore, and we're going to make sure that we have adequate access for all our patients.
Thank you. I'm just going to pick up on one other, we've had some questions about learning disabilities and the face-to-face issues, same from the dementia. I think we probably covered most of those things, but is there anything you want to add? I
would say that Enfield has improved greatly in undertaking learning disability health checks. In fact, last year we were one of the highest performers in North Central London. I think it is part of one of our priorities this year, both from a primary care network and from a practice perspective. And we're doing a lot of quality improvement across the PCNs on improving learning disability care as a whole. As part of the PCN care homes element, there are a lot of learning disability homes with vulnerable patients, and we've been going in to administer flu jabs to them as well, to a large extent. So I think we've realized, especially I think early on in the pandemic, there was about 150 learning disability patients who passed away from presumably the coronavirus. And in the second wave so far, there hasn't been any. So I think we have learned as a system how to manage some of our vulnerable patients more effectively.
Thank you. I'm just going to ask one last question, which is focused at the GPs, which, well, it's not actually, it's everyone, but about language barriers, particularly the e-consult system doesn't really support other languages, as I understand it. How's that going to be overcome?
Again, with e-consult Lite, we learned that quite quickly, and in some of the practices that we serve in the east side, the feedback was quite quick that this wasn't suiting their needs. So we dialed back, and in one of our practices, the e-consult offer is much more weighted towards e-consult Lite than the other. And as I said, the technology is at least 2 or 3 years away, I think, from suiting most patients' needs. But we're making the best we can of it, and just be patient and work with us. We're happy to get feedback. I'm sure all practices are.
Thank you. I'm going to move on to primary and secondary care access issues, and I'm going to just thank the GPs. You can have a break for a moment. If I could just ask Chase Farm and North Mid for some updates on what services are actually available and what changes have been made, and how have people been informed of what those changes are. So maybe we start with Chase Farm. Is that Natalie or Emma? Amy, sorry, Emma.
I'm North Mid.
That's okay.
Sorry.
I think Natalie has dropped off the call, so I can take this one.
Okay.
I'm sure she'll come back on in a sec. So in response to the COVID-19 pandemic, across the whole of our trust, so we have 3 key hospitals in our trust, we have temporarily reorganised how and also where some of our care is provided. And this is to make sure that we can continue to care for all of our patients safely. And also to support the trust through the winter months, as people will have heard on the news, that they can be difficult times for the NHS. So in some cases, patients may find that they're having their appointment or their procedure with a different clinician or in a different location to where they expected. But we are trying to give people as much notice as we possibly can about that. So we are informing patients via either their letters or the telephone calls that we do with them prior to their appointments or their procedures. We are trying to keep both our patients and obviously our staff safe, and when patients come into our hospitals, things will seem really different. So some examples of things that we are doing is that when you arrive at Chase Farm Hospital, all patients have to go through one entrance. And everybody will have their temperature taken with a forehead temperature thermometer. They will be asked to gel their hands or to wash their hands for the 20 seconds. And we are asking patients, if they are able to wear a face covering at all times in the hospital. And just something to say is that our staff are also go through these. They go through a separate door to come in, but they also all have their temperature taken. They all get the same screening questions that we ask our patients, just about where have they been and how are they feeling, making sure that they don't have any symptoms. And all of our staff are wearing surgical masks, like you can see that I'm wearing throughout our building as well. So there's some of the things that we're putting in place to help keep our patients and our staff safe. Patients who are coming for operations or endoscopy procedures are asked to self-isolate for a few days before their procedure, and they also all have a COVID-19 swab, which they need to have a negative swab result before they can come for their procedure. And that's all explained to patients in the preparations that we do with them and the phone calls that we have with them prior to those procedures. Another area that we have that we've made some changes in is our urgent care centre, our urgent treatment centre, which is still open. It remains open to both adults and children. However, we have separated it from the rest of our main hospital. And this is because that's one of the places where we are most likely to have patients come who may have symptoms. So we have separated it from the main hospital to keep our planned care patients safe. And we also have separate waiting areas within there to keep those patients that potentially have symptoms separated from other patients that are coming for other reasons. We do ask if patients do think they need to visit us, that they call NHS 111 first, and then NHS 111 can guide them into the correct place or the correct pathway to use for their for whatever need that they have. And this may be booking an appointment at our urgent treatment centre, which they can do, or they may be directing into other services. And there is more information on our public website that everybody can access, and we keep that up to date with the changes. I'm sure everyone can appreciate things keep changing, and we keep reviewing what we need to do, and so we keep that updated as well. In the main section, there's a link on our website, and there's also in the news section on our website as well.
Thank you. And I see Natalie's come back. I don't know if, Natalie, you have anything. I don't know how much you heard of that. But we were just saying about what have the changes been at Chase Farm, and Amy's done a very good job of talking us through, I think, most of the changes, if not all of the changes. But is there anything you want to add? Can I just make a comment and a question that maybe you can address, which is some of the services have been moved out to Barnet and Edgware hospitals, and they are difficult for Enfield residents to get to. So is there a plan to bring these services back onto the Chase Farm site?
Hi, sorry everyone, just at the wrong moment I had some technical issues, so thanks Amy for standing in. So all of the changes that we have made over the last few months are temporary and have just simply been to make sure that we can safely provide as many services as we possibly can for the whole community. And I do appreciate that that has not always been straightforward for everybody. So everything is temporary, and as things change in the community in relation to the amount of COVID, then everything will be reassessed with a view to changing things back. So yes, I hope so. Obviously, we don't know what restrictions will remain for healthcare in order to protect patients. In particular, here at Chase Farm, it's our elective patients that that we have made most of the changes in order to protect. So that's not a full answer, Noelle. I appreciate that, but everything is definitely temporary at this stage.
Okay, thank you. And can I ask North Mid colleagues if you want to have a go?
Thank you, Noelle. Yes, thank you, Noelle. I think the first thing to reflect, I think for patients, things have changed and keep changing, and I think we appreciate, you know, that can be distressing if you're unwell or bring a level of uncertainty. And I also want to say our staff are working really hard, and they're working with these changes the whole time to make sure that patients get the best experience at North Mid. But the first thing to say, as I said, first of all, was that we continue to run the full range of services at North Mid. There were some changes earlier in the pandemic, but actually now we are running the full range of services. But we've had to introduce some measures to help stop the spread of infection. So when you walk into the hospital, we have reduced the number of entrances that you can come into the hospital, but you will have a temperature check, you will be given a mask. We've also really tried to think about for those people who can and where it's clinically appropriate, and all our doctors, myself amongst them, have made sure that we've sort of reviewed people. But if we will offer virtual consultations either by video or by phone to instead of bringing people in onto the hospital site. And actually we've had quite a lot of feedback that people find this really quite convenient. You know, if it's about feedback for some results, or you don't really need to be examined by a doctor, actually, you know, the issues of coming up to North Mid, trying to get there, actually it's easier if we can do it remotely. So we've had a lot of good feedback from that. We've also had to change the visiting arrangements, and I know this has been you know, something that we've really wrestled with within the trust, but actually, and Noelle, you've been part of the conversations through our ethical panel, but we have had to limit visiting to really kind of keep everybody safe. But we will allow visiting in some limited circumstances, particularly if someone has dementia or a learning disability or a significant mental health issue, if they're at the end of their life, or women who are at their 20-week scan or giving birth, and parents of children. have we communicated this? And I think, you know, we've had feedback about the best ways to communicate this. We've put this on our website, and I would really encourage people to look regularly because it does change. And we've had a new website and again got better feedback around that. We put it in our outpatient letters and our communications, but we also send newsletters out to Healthwatch, to the local community and to GPs.
Thank you. And there's a message in the chat that someone had a retinal scan, which was a problem, and they were seen urgently at North Mid, and you were brilliant.
Well, that's why we're here. We really like to hear that, so thank you.
And can I just pick up on just one thing, which is a link with GPs. So GPs are using video technology or digital technology or whatever. Are you trying to use the same technology so that patients will find it easy? So
there are various platforms that we use via the NHS, things like I think it's called Consultant Connect. Generally, a lot of it's done by phone, actually, and a lot of our patients prefer the phone, but I appreciate people who might have hearing difficulties or, you know, that have, you know, that they need support around language. That's more difficult. And again, if there are particular issues, we will see people. But yes, we do have video conferencing, but I can't remember if it's exactly the same platform as GPs, but it's a very good point, and I can take that away and ask my digital leads in the trust.
Thank you. Thank you. Does anybody want to come in on any other comments?
Yeah, so I'm Fahim Chowdhury, one of the primary care development leads. So GPs use, I think in Enfield, pretty similar video consultation portals. One of them is called Accurix, and the feedback we've got from patients has been very positive. Obviously, there are patients that aren't very tech savvy, and we make extra effort and extra time for them to be able to call us. But our first port of call is a telephone call, and if we can't perform video calls, usually it will be a face-to-face if we need to see them. But we've had positive feedback, and it's a very easy to use. They get a link sent to them on their phone. They just go into the link and they'll come up instantly with a video call with the GP.
Excellent, thank you.
Just to come in, Noel, I think
yes, please do.
One of the hospitals using is called Attend Anywhere. So I know the Royal Free are looking at that. Some of the local sort of community trusts might be looking at that too. And it just allows a virtual interface between patients, as the face-to-face outpatient may not be quite as active as it was before.
And so what I'm hearing is that from the patients trying to use the system, actually it's not so important that it's the same, it's just important that it's easy to use. I'll take yes from everyone.
If I let Dr. Garg answer if they're using it, because we don't have any experience of the outpatient ones that they use.
So I would like to say two things, more to our patients to get the feel of what the work goes behind all this. So we proactively go through our list of who's I'm going to see tomorrow, let's say, for example, or a week in advance. And anyone I think I need to see face-to-face, which is a small percentage, but we do let them know that we'd like to see them face-to-face. So they are seen. And there are lots of people we have to proactively shield, and those are obviously given a telephone consultation. There are some colleagues of mine, let's say my podiatrist, who needs to see a lot of things. They would like to see majority of them, but if someone cannot come, they have an opportunity to use video consultation to do the same. In diabetes, well, the technology has moved massively. So a lot of my type 1 patients can give me all the data that I need through electronic communication with us. And that is something we could touch at some point in this conversation is diabetes patient, even if you're using a simple glucometer, you can link it up to a web-based service and we can see all your readings, everything here. So it will be almost like a face-to-face consultation because you're going through your sugar, saying what happened on Wednesday lunchtime, why your sugars were so high, etc., etc. So there's a lot of technology around. And I think COVID, this is something better that's going to come out of COVID, is we'll learn how to use technology so much better.
So, well, just if you stay there, I'm going to put this next question to you as well, which it's about diagnostics really and access to diagnostics. What you're talking about is telemedicine in effect, or remote diagnostics. That's great if you can afford these devices. What's going to happen to the sort of groups who, particularly for our communities, who might not be able to afford these remote technologies? How are they going to be able to access it?
So the remote technology, which is mainly used in development, is in type 1 diabetes, which is NHS funded. So it's not personally funded. So the sensors called Libre sensors are NHS funded. So if you meet the national criteria, you're given a sensor which downloads on your phone or a kind of a download device. Pumps, which a lot of patients use, are NHS funded, so they're not privately funded. So that's also. We don't have very good access to what is called CGM in North Central sector, but it's something we're working on, and it's an issue. Kind of, it's a very expensive device, but again, NHS funded. There is a new drive coming through. The pregnant ladies with type 1 diabetes could have these expensive devices funded by NHS. So a lot of this is NHS funded. But the problem is majority of people who have diabetes is actually type 2 diabetes, who don't need all this technology to have a live sugar readings. So they can use their own glucometer, which is funded by NHS, provided by GP, and all of them come with a cable which can just plug into your computer. For those patients who are listening, they can create an account on Diasend, D-I-A-S-E-N-D. It's a free account. And when you call your clinician next time, you can link your account to our account through the code, and then we can see all your readings here. So it's not really any money involved in this. It is just being able to have a computer at home and a lead to plug in your glucometer to the computer. That's it.
Okay, and I'm assuming that would also apply to a smartphone. You could just plug it into a phone as well. I'm not technically savvy.
So a lot of smartphones with kind of cloud or internet access will automatically upload this to the cloud service, we can see. But otherwise, you can just plug it into your computer.
Can I just caveat that slightly? Although whatever Dr. Garg said is absolutely correct, there are strict criteria for funding for all of these.
Yes.
We get quite a few queries from patients who don't fit the criteria, and I think a lot of that needs also potentially a consultant to make a decision on that as well. So it's just important that it's not open to all patients, and the funding is where the most need is, and that decision is often made by a consultant diabetologist.
The other thing I would also add is that the vast majority of patients with type 2 diabetes don't necessarily need to regularly monitor their blood sugars. So I think we just need to be careful about what we're talking about here. The other thing that I would also add is that one of the questions talked about blood pressure management, and that's really important in patients with type 2 diabetes. And we are looking to see whether or not we can provide some blood pressure monitors for patients to keep at home for monitoring as and when the monitoring period is being used. So that's something that's being explored. I know one or two of the directorates within NCL have started to roll that out already, but that's something we're actively considering in Enfield.
Thank you. And can I just ask, Dr. Garg, you mentioned a website or a linkage. Can we just share that? Can someone try and find out and put it in the chat, please, for people that
so the first three words of diabetes, D-I-A, and then you send as S-E-N-D, send, diasend.com, and you can create a free patient account. You can download your glucometer. I would recommend whoever uses a glucometer, it gives you a kind of different perspective rather than one reading, lots of kind of downloadable charts. And I probably won't reveal the clinic code here because I don't want everybody who's not even my patient to link their readings to us. But our patients, yes, when they speak to us, we're more than happy to support them through linking their accounts.
Okay, that's great, thank you. And the second part to that question was about access to routine diagnostics, so to blood tests, x-rays, or imaging equipment. Can anyone say if that's back to normal? What was
So Noelle, thank you. I thought it might just be helpful to sort of comment. So we continue to offer x-rays and diagnostic appointments at North Mid, and you can be referred for this by your GP. but we are using sort of appointed times. We've tried to move away from people just walking in, and that's also the same with blood tests. Just you do need to book a time so that we can make sure we don't have lots of people in the hospital mixing. We have to be careful about the numbers of people who come in to maintain, you know, to keep people safe from COVID as far as possible. There are also community clinics for blood tests that we've also set up, but again, you do need to book them, and your GP can book them.
Thank you. Does anyone else want to just comment on that?
Yeah, so most of Enfield practices have been advised that they can do their own phlebotomy services, and there's support there. So, for example, I'm a partner at Angel Surgery, not too far from North Middlesex, and we have a phlebotomy clinic every Wednesday, and patient feedback is they will, especially with the current fear in going into hospitals, patients absolutely love coming into their own surgery to have their phlebotomy done. So, so there's no issues, particularly with getting phlebotomy done, especially when practices are doing their own at the moment. And I think something we need to consider looking at in the future in terms of is this good for patient compliance, because they do like coming to smaller, familiar places.
Again, sadly, it's not commissioned long term. It's only commissioned till the end of March. And I do encourage if patients are liking that the service being provided at their practice, that they feed back positively, because that's the only way it will be extended. I would say that diagnostics as a whole, there are still significant delays, especially for routine diagnostics. We're finding across all providers in Enfield from primary care. I don't know if Alpesh and Fahim have any sort of comments about ultrasound and ECG, etc.
Yes, so in terms of ultrasound, the number of providers that are offering it, the number of hospitals that are offering it, isn't as great as it was, and we're channeling quite a lot of those requests through one particular route. So that particular provider has got slightly longer waits for things like ultrasound. ECGs, again, they used to be walk-in services, but as Dr. Witcher has said, by necessity, we need to give patients appointments. So those are still available, but it's taking a little bit of a process to try and get those arranged. But the capacity is coming up to speed, but they're just at a bit of a delay before they come on. And again, with phlebotomy, lots of sites are providing it, and provided patients are flexible, they can get phlebotomy turned around very quickly without having to wait more than a few days. So gradually the system is coming back, but it's just slightly different in the way people are accessing it.
Sorry, can I just also add, so we have been gathering patient feedback from across the practices about phlebotomy, and it has been overly positive so far. So as Sarah said, if you are happy, you know, to provide that feedback would be really helpful.
And again, I think that's really useful to know, but how should we do that? What's the best way, and who to?
So if someone does have it, a patient does have it within a GP practice, then they can complete a survey, a really 2-minute quick question that they could complete with someone or do it on their own. So it's a paper-based survey, and it's also, I think, on SurveyMonkey. So you'd have to ask your practice what option they've gone for.
And is it different to the Friends and Family Test survey?
It is, yeah. It is, yeah. It's specifically for phlebotomy within GP practices.
Thank you. I'm just going to I'm going to make 2 comments. One is that there's a bit of chat in the chat box about how involved are patients in helping design the technology solutions that are being proposed, and what role do PPGs have in that group. And I'm going to let you think about that, because Dudu has, from Public Health Enfield, has joined the call. She was just a little bit late, and I don't know if she wants to add anything. We've been quite a trip through all sorts of different services so far, Dudu. I don't know if there's anything specific you wanted to say, just as a general introduction at this point.
Scott, can I just interrupt 1 second, and just, we're all so immersed in the industry, we forget sometimes some of the acronyms that we use, and we've got 60 people in our forum. So PPGs, which I didn't know until last year myself, is a patient participation group. Is that correct?
Yes, that's correct.
Yes, brilliant. Okay, sorry. It's just that I know because I'm new to the industry, you forget these things and we all use those terms. So thank you.
That's good. The floor is yours if you'd like to just share any. We've been talking about changes and what's happening and what's available at the moment.
Hi there, Noelle. Can you hear me okay?
Yes, thank you.
And I'm not sure, I've tried to put my video on, but I'm not sure whether you can see me or not.
I can see you.
Oh, okay, great. Hello, everybody, and sorry for being late. I guess from my perspective, I had joined the call just to see whether there is whether anybody has any questions regarding issues around flu vaccine or any questions that they have around COVID infection and the public health advice relating to that. Really, you know, and I'm happy to take any other questions, you know, that irrespective of the ones that people have already submitted as well.
Well, you'll be pleased to know that the next section is all about flu vaccines and COVID vaccines. But before we get there, there's one question that I do want to just raise because it covers everything. So this is a question from one of the BAME community. They've been worried about using health services, both the GP and hospital, as a Black person, as they feel more vulnerable to COVID. So what advice can you give them to reassure them?
I'm sure that my colleagues on the call from primary care can also add to that, but I do know that certainly primary care services and other health services, hospitals, pharmacies are taking very significant measures in relation to infection control and prevention to minimise the risk of coronavirus spread. I don't know whether one of the GPs who is on the call wants to just provide some examples of the things that they're doing within their practice in relation to this. But I would very much encourage anybody who has any outstanding or particularly urgent medical needs to contact their primary care services, their GPs, to receive the support that they need rather than delaying. I will hand over to one of my primary care colleagues just to give some examples of the sorts of things that are happening in primary care in relation to infection control.
Yeah, we NCL, North Central London CCG, have commissioned intense training for all the practices in terms of infection control and using the latest evidence in how to reduce the spread and catching infection control. So lead GPs, lead nurses have gone on actual face-to-face training for this because it's so important. And we've all taken very stringent rules in terms of preventing the spread of COVID. So particularly, you know, we do ensure that there aren't clumping of patients turning up all at the same time, one in, one out, ensuring everyone wears masks, constantly having to use sanitizer. And we're quite confident, also infection control, North Central London are confident that the spread of COVID in our health centres is going to be at the most minimum, very unlikely to catch COVID. And that should encourage our patients to be turning up to our surgery.
So Noel, can I just add to what Fahim said? So droplet spread is the main mode of transmission and hands. So all practices will be wearing level 2 PPE, which is mask, gloves and apron with or without visor. And that's going to be something that's going to be changed between patients. Touch points are cleaned and processes around people coming into practices will ensure that the prospect of spread is minimized as much as possible. So face masks, hand washing, and a number of practices have made changes internally with perspex or glass sort of fittings to try and minimize the spread of that too. And as Fahim says, there's been a significant take-up of the specially commissioned infection prevention control training on offer to practices.
And just to be clear, that training is also available to all staff, so reception staff, etc.
So the way the training has been designed is that you'll have clinical leads and administrative leads attending the training, and then cascading that on a basis that takes account of what the local practice environment is doing. So the outside in terms of messaging, the internal messaging, and internal organisation and patient flow. The other thing that primary care isn't doing is undertaking processes that generate an aerosol, which then changes the way things may be spread. So, for example, we used to do spirometry in primary care, which we don't do that anymore because that's an aerosol, potential aerosol generating procedure. So we've changed a few things internally, both from an IPC control, but also the sort of assessments that we do too.
Thank you. And Emma, did you want to come in?
Yes, I think it would just be helpful. We've got a very kind of comprehensive program around infection prevention control at North Mid. As I talked a little bit about when you come in, what would happen with temperature checks, masks, being asked to sanitize your hands. But we've also invested a lot of time and money in our cleaning processes. So between every single appointment in outpatients, the rooms are cleaned. We have enhanced cleaning across the organisation. We also test staff regularly, and we've also sort of we have what we call 2 different pathways. If you're coming in for a planned operation, you would be asked to have a test before you come in and have that operation and keep yourself safe for several days. And the staff who are performing that operation would not be mixing with staff who are looking after emergency patients on that day. So we're doing everything possible to try and prevent people getting exposed to COVID while they're in the hospital. And our staff wear masks. We have very clear rules for our staff in the hospital, what we expect them to do and how we expect them to reduce any infection between themselves. If you come into our waiting room, you will see that a lot of the seats have been blocked up so people don't sit closely to each other. But I think what's really important is if you are not very, if you're unwell, if you need to see a doctor, if you need to be seen or a nurse for your medical health issues, you must do, because actually it's really important that your other health issues are treated.
And there's just a question in the chat box. So while you're on the screen, so to speak, it's about cleaning of the chairs and the toilets. Has that also been?
Yes, absolutely. And what I would say is between and Dr. Anikel may want to come in and say this because he's sitting in the clinic day in, day out, but actually the doctor has, you have to leave the clinic and the clinic room has to be cleaned in between yourselves. And yes, the chairs are being wiped down regularly.
I'm actually sitting in a clinic room and there are 2 cleaners outside who clean every chair. The moment you get off the chair, a patient gets up from the chair is cleaned. My room is clean in between every patient. I'm actually amazed how hard these guys are working at the moment. Absolutely amazing.
Thank you. I'm going to move on. I'm conscious of time, and I think, Sarah, you might have to leave at some stage shortly.
Right now, actually, I was just typing in the chat. So thank you so much for inviting me, and please feel free to ask me to attend to ask any questions or any questions in between. Alpesh, I think you're staying, are you?
Yes.
Yeah, yes, I can stay. Yes, I can
Brilliant.
stay.
Thanks a lot. Thank you.
Okay. Thank you very much. Thank you. Thanks for coming. I'm going to move on to some, just again, we've had a lot of questions. So I'm just going to move on to vaccines and some questions specifically around the flu and COVID vaccines. The first one is about vaccine and chemotherapy. So will the COVID vaccine be more dangerous for someone undergoing chemotherapy? Who would like to take that? Do we know?
Shall I come in
Go ahead,
quickly?
Emma.
And Dudu might want to. This is very new. We can't answer that at the moment. As you may be aware, the vaccine was approved about 3 hours ago. So we will be waiting for the data and the Q&As from NHS England and Public Health England over the next sort of 24, 48 hours. So when we have that information, we will share it as soon as possible.
Thank you. Do you want to add anything?
Not really specifically around that point about COVID vaccine and chemotherapy. There is likely to be some groups amongst our resident population who, for one reason and another, are unable to receive COVID vaccine, and that's the same for any vaccine. And I think that that's really, for me, puts we all have a responsibility to protect each other, and vaccination is one of the areas of healthcare where you receive a vaccine not only to protect yourself, but also to protect those around us who are not able to receive that vaccine and have that individual protection. So I know that people's clinicians will be very closely looking at this in relation to their individual patients' care. But I would very much urge residents, when they are invited to have their COVID vaccine, to take that offer up.
Yeah, and I would entirely agree. I think, as medical director, when I talk to my medical colleagues, we're all really keen. We think that actually, we're wanting this vaccine ourselves. I think it will be offered to staff in healthcare settings because actually we need to protect each other and protect our patients.
And similar to the effect on chemo, what about other medications? Will the COVID vaccine interfere with other medications they might be taking? Is there any research knowledge on that?
It's very difficult for us to comment around specifics around the COVID vaccine because we just don't have the information available at the moment. But I think maybe what would be useful is once we have access to that information and it has been published more widely, then we can always do another session specifically on COVID vaccine if people have questions or queries that they want to ask. I would certainly be happy to do that, and I can't speak for others, but I'm sure my other colleagues would be as well.
And the other thing that I would say also is that we've talked about the vaccine, but there are lots of different vaccines which will have different characteristics. So I think we just need to hold until stuff becomes much clearer, I think, is what I would say.
Yes.
So thank you. And I think what you're demonstrating is why people have this concern, because there are so many unknowns. And one of the questions being asked at the moment is, how confident are we, and I haven't read the clinical trial, so I don't know, but how confident are we with the results that are being published at the moment in terms of vaccines, usually go through more extensive testing than this is done, and people need to be reassured that it will not have any long-term implications?
I can start on that question. So I think there's a number of points that I hope will reassure people. First of all, many of the COVID vaccines have not started from scratch, even prior to COVID. There were animal-based COVID vaccines prior to this most recent pandemic that were used in veterinary science. The process that has been undertaken that has allowed the kind of speed of the vaccine development and licensing is that clinical trials have been run in parallel, and the production of the vaccine was started even whilst the clinical trials were running. So there actually haven't been any corners cut or any processes missed out in terms of the investigation procedures that any other vaccine would have undertaken. All of the clinical trial processes have been undertaken. They've just happened all at the same time rather than one after the other. The other thing that is worth also mentioning is that all vaccines are monitored by the regulatory body, and there is a process for identifying and both members of the public and also clinicians can notify the regulatory authorities if anybody does have a reaction. And that's for any vaccine that is out there and any medicine, in fact. So there is also a process that will be used to look at any new information that comes out that hasn't been picked up in the trial, and that's the same as any other medicine or vaccine that is currently available today.
Okay. Thank you. I'm just going to move on, conscious of time again, I'm just going to move us on to one final question, which was put to us at the start, really, which is people with learning disabilities and autism have found that they can't get the appointments to the diabetes nurses or asthma clinics, and they're worried about their conditions and that they're not being monitored. Some people have got issues about medication and getting hold of their medication, and they've been going back to the doctors a number of times to see if they can get it corrected. And people feel it's not happening. So what's your advice to sort of help resolve those issues? Anybody?
So in terms of primary care, I would say that long-term conditions are something that's really important for us in Enfield, and certainly for the Federation. And I think I would say the process should be no different. If you're wanting to access primary care, whether you have a learning disability or you have other clinical conditions to try and access your practice, they will be monitoring these things. It's important. And I think if there are recurrent issues, they will start to become apparent, because we collect data on practices that are performing well or not, and so that will become apparent if it's not happening. One of the things that we have seen, just as an aside, is that patients with type 2 diabetes, last year in Enfield, we had very good results for patients who are controlled for blood pressure, sugar and cholesterol. What we're seeing this year is that because of people being a lot more sedentary, is that their diabetes control is less good. So I would really encourage people to contact practices, because we do want to try and be as proactive as possible.
Thank you. Does anybody else want to come in?
Yes, so just echoing on what Alpesh is saying. So obviously we're in everything, we're 6 months behind in terms of our chronic disease management, and we're actively getting patients to come in, and they're very happy that we're calling them to come in and get their diabetic review done. Something unfortunate we can't do on a telephone, because we need to do the blood pressure and foot check, and I think spend a bit more time with them in managing their diabetes, and hopefully the people that have learning difficulties and other disabilities, they'll be further encouraged to come in. So there's additional checks for them that they need to have done. So there's 2 safety nets for them that primary care will use to ensure they come in and see the doctors.
Does Dr. Garg want to come in as well around this?
I'll probably say if you're known to our service and you can't get an appointment, which is actually unusual, but you can always call our nurses through the hospital switchboard. If you ask them to connect to diabetes nurses, they'll either answer your phone. If they're not able to answer your phone, you can leave a voicemail and they'll come back to you. So we are available, and we will come back to you if you leave a message. If you need any help, any urgent help, we can always accommodate in a clinic if you're able to come and it's safe to come as well. And if you think a telephone consultation is not the best thing for you, do leave a kind of message. You can come to Diabetes Secretary through switchboard again. That's again 9 to 5, Monday to Friday. So we are around. We're absolutely happy to help.
Thank you. And I've just got one last comment coming through in the chat box, which is about the vaccine for carers. I think we've heard progress on the flu vaccine for carers, but I'm not clear if carers are involved in the first wave of the COVID vaccine. Does anybody have any clarity on that?
If I can, so again, the JCVI will tell us which groups are going to be prioritised for which vaccine. So I think that's still a question mark at the moment. There was something that was published late last night about whether patients who aren't registered with particular practices and who may be carers, whether or not they'd be eligible as part of something that's being contracted through GP practices to provide when the appropriate vaccine is available. So I think they're thinking about it, but it's still a bit of a question mark at the moment. Okay.
Thank you. Thank you, everyone. I am going to stop there, but just before we leave, are there any last comments from the panel, or is there any burning questions in the chat box? Good, I think we must have done a good job then. Okay, thank you ever so much to everyone. So all the panel members and all the people that's taken part. Just to remind people that we will hold another Q&A session towards the middle of January, which will look at long-term care and support services for the longer-term patients. So Age UK, North London Hospice, Dementia Specialists and Marie Curie team have signed up to take part in that. There's a message in the chat box. Please fill in the evaluation form. We really need your feedback to see if we're going in the right direction and if we're getting the questions that you want answered, addressed. So thanks very much. Again, thank you.
No, just to say I'm really sorry, everybody. I had a major outage of electricity in my house. So thank you so much for Noelle for stepping in for me today. And really interesting to see from a viewer's perspective, so thank you so much as well. And I'm Sue Jane, I'm from Healthwatch Enfield. If you are running any online meetings, please do invite me. I'd love to come along, and I won't have an outage next time, I promise. So thank you so much again. Thank you, Noelle.
Okay, thank you. Well, I think on that note, we've sold Healthwatch enough, so I'm going to say once again, thank you very much. Please fill in the evaluation form. Enjoy the rest of the day. Everyone that needs it, get the flu and the COVID vaccines, hopefully as soon as possible. And everyone take care. Thank you. Bye.
Thanks,
Noel.
Thanks a lot. Thanks, Noel. Thanks. Bye.
Bye.